So thank you for the invitation to share my research with you. So this is the topic I'm most passionate about in my everyday. I'm going to start with the land acknowledgement. We pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. In terms of disclosures, Nafis already introduced that I held the University Research Chair in Knowledge Translation to Patients. And the other funding that I've received is for invitations for presentations. And then two of the Cochrane reviews that I will be discussing were funded by the Canadian Institutes of Health Research. So I'm going to start with a story, a real story of an 84-year-old woman who received surgery results. She found out she had a hysterectomy with removal of the ovaries and fallopian tubes. It showed that the cancer had invaded into the wall of the uterus and also 0.5 millimeters into the wall of the cervix. Her lymph nodes were negative. So because of that tiny little bit into the cervical wall, it was diagnosed as stage 2 uterine cancer. So the next step was to go see the radiation oncologist who confirmed the diagnosis and discussed 25 radiation treatments that are external treatments given Monday to Friday for 5 weeks. The oncologist explained common side effects of diarrhea for 4 to 6 weeks, uterine fibrosis, fatigue, and skin reactions. And I purposefully left the head of the woman off because really this is just the report that was in the chart. So is this really the best treatment for this woman? So if you Google the National Cancer Institute in the US and look up endometrial cancer or uterine cancer, you can actually see that if the cervix is clinically uninvolved, which means before surgery, but there is extension to the cervix as noted in the pathology report, which it was, radiation therapy is considered. So when it comes to evidence-based clinical decisions, if we think about this one's the McMaster framework for what's an evidence-based decision. Research evidence is one piece of that around what's the best treatment, but we also need to think about patient preferences and actions, what healthcare resources we have access to, and also the clinical circumstances. And really, it's healthcare professionals' role, which is how do we pull that all together? So who is this woman? So now I put a head on the person. So this person has medications for dementia and previous strokes. Her personal care needs, she needs support with showers and encouragement to change her clothes. Was unable to manage when she had diarrhea during COVID. And her husband, who's 83, drives her to her medical appointments. But she does have an active lifestyle. She plays bridge twice a week, plays the piano daily, and she curls twice a week. So at the appointment with the radiation oncologist, the family member shares her mother's personal care needs and asks about other options because coping with diarrhea for 5 to 6 weeks is not really going to be that feasible. So ask about other options and what's the chance of recurrence by option? And so the radiation oncologist said, if she was to have radiation therapy for 25 doses or treatments, there's an 8% chance of recurrence. If she was to have brachytherapy, which is a type of internal radiation that's given once a week for 3 weeks, there's fewer side effects and there's a 12% chance of recurrence. And if she has no treatment, then she has a 30% chance of recurrence. And so really, what's the best treatment for the decision for this woman? So this case that I've just shared with you is really consistent with what happens all the time in the healthcare system in Canada, Ottawa, and around the world. So 50% of patients are not offered more than one option. Clinicians are poor judges of patients' values and preferences, and hence the patient often achieves poor quality decisions. And there are effective interventions or decision support tools, but they're not routinely used in clinical practice. So the research that I'm going to share with you today is based on the Ottawa Decision Support Framework, and we have we just published the 20th anniversary updated of it in 2020. We pulled Annette O'Connor out of retirement to be involved as the knowledge user, the key person for the update. And so this framework has been used for more than 45 decisional needs assessment studies, 24 randomized trials of decision aids, 2 randomized trials of decision coaching, and over 250 studies have used the decisional conflict scale. It's been used for over 100 decisions with over 50,000 patients in 18 countries. So according to this framework, there's 3 sort of key concepts. The first is the decisional needs that are what needs to be addressed to help the person with the decision. And so it depends on how difficult is the decision, what stage of decision making, do they have decisional conflict, do they have adequate knowledge, realistic expectations, clear values, and do they have enough support and resources to make the decision? Then depending on what their needs are, we could provide decision support interventions that will help address their decisional needs to improve the decisional outcomes, which is a quality decision defined as informed and based on patients' informed values, quality of the decision-making process, so reduce decisional needs and decisional conflict, and then the impact around implementing the chosen option and adhering to it or continuing with it. And then there would be appropriate use of healthcare services and costs. The other framework that I use all the time is the knowledge to action framework. And this framework is really focuses on implementation of evidence into practice or knowledge into practice. So at the center of the framework, you can see where it's knowledge creation, so individual studies, knowledge synthesis from systematic reviews or from practice guidelines, knowledge tools. You can talk about patient decision aids that fit here. And then in the outer part is how do we move it into practice, or how do we change practice to really be able to support patients, for example, involvement in decisions, could be used for improving hand washing in healthcare. Like, it's an implementation framework around implementing some kind of change. So in my presentation, I'm going to share the definition of shared decision-making. I'll talk about the different tools to support patients making these decisions, and then I'll wrap up with some discussion around implementation. So shared decision-making is a process by which decisions are made by the patient plus their family, if they want their family to be involved, and the clinician using best available evidence and patients' informed preferences. So not a lot different than the definition I gave of what's a good healthcare decision. The 3 key elements of shared decision-making is, one, that we have to be clear around what is a decision. Like in that situation that I just talked to you about, there was actually no decision presented. It was just, oh, she needs to now have radiation treatment. And there's no discussion around alternative options, including doing nothing, or in the case was use of brachytherapy or a different type of radiation. The second element of shared decision-making is information exchange. So what are the options, benefits, harms of the options? And in this case, the family prompted that information around what are the options. And then values and preferences are really key. What's really important to the patient and their family around what are the features? One is 25 treatments, for example, coming back and forth every day for 25 treatments versus 3 treatments. And then the other value is around the side effects. And so with the one type of radiation, there's a lot of side effects. And with the other type, the dose of radiation is very specifically given where it's needed, and there's much less side effects. Oh, and then Weston calls this the crux of patient-centered care, that in fact, if you look at the definition of patient-centered care, we're not providing patient-centered care if we don't talk to patients around what's important to them, what do they value. So this study was done by my colleagues in Quebec City that looked at 110 Canadians from 10 provinces. And what they said is that they were only 43% of the time, often or always, told they had choice of treatment, so less than half. 45% of the time, they were told advantages, disadvantages, benefits, harms, pros, cons. And 39% of the time, they were often or always asked their preferences. And what they found is that there was lower shared decision-making if they were older age, living rurally, living in Quebec, or not being white. And so there's a lot of disparities around even who gets involved in healthcare decisions. There's also a lot of myths around shared decision making. So it's not compatible with clinical practice guidelines. What we need to do is take the clinical practice guidelines and also talk to patients around what's important to them. It's actually around bringing the two together. Uh, Lots of people say, oh, we already do it. And in fact, in this clinical situation, probably the person would have thought they were doing it. Not everyone wants shared decision making. Uh, Shared decision making takes too much time, or it's really easy. Just give them a decision aid and you don't need to talk to them about the decision. Like sometimes people think, or they say to them, oh, here's your options, you figure it out, as opposed to there being some kind of discussion. Natalie Joseph Williams did a systematic review looking at patient perspectives of barriers and facilitators to their involvement in shared decision making. And what she reported is their capacity to participate depended on having knowledge about their disease or condition, knowledge about their options and outcomes, but they also needed to have knowledge about what was important to them, so about their personal values and preferences. But consistently on the right side here, they also identified a huge power imbalance. Like they don't feel comfortable being able to be involved in these discussions unless they're given permission to participate. They feel confident in their own knowledge, or they feel self-efficacious in using their own skills to be involved. In the case I just shared with you, if the daughter wasn't in the room prompting and asking these questions, the patient would have just gone on to have external radiation, which they didn't have in the end. So what are the tools then to support patients to make decisions? Dr. Dreesen's published this paper around all of the different types of knowledge tools, and there's a whole list of them here. I'm just going to focus on a few of them. But what's really important when it comes to knowledge tools is it's important to look at what's the purpose of the tool. Is it to inform or educate? Is it to provide recommendations? Like clinical practice guidelines often have a patient summary that summarizes the recommendations. Is it to support decision making, or is it to engage patients in shared decision making? And so I'm going to focus on ones that really are more active, supporting patients to be involved in health decisions. So one of the interventions that's super easy that we could be using is called question prompts, or the ask intervention. It was developed by a group in Australia, and there's 3 questions. What are my options? What are the possible benefits and harms of the options, and how likely are they to occur? And that's actually what the family member used in that consultation. They were able to ask this question and feel comfortable asking. The studies that have evaluated this intervention show that 87% of patients asked 1 or more questions if there was a decision involved, 43% asked all 3 questions, and that it improved the information given by physicians, and more physicians actually involved patients in the decisions when the patients prompted that information. And so the UK actually took those 3 questions and they changed the 3rd one to how do I get support to help me make a decision that's right for me? And they used this part of the Aqua project and a huge campaign across the NHS, National Health Services, where they actually told everybody in the country, you have a right to ask these questions every time you go into the healthcare system. And so this is a simple intervention that something all of us could be doing anytime we're in and out of the healthcare system. The other thing that Natalie Joseph Williams found in their review is that when they asked the patients, how can we overcome the barriers? They said that they wanted nurses to explain the information, provide support by listening to patient preferences, and then provide the doctors with the patient preferences. So the patients don't feel that they can override that power imbalance, right? They think they need someone else. But the problem is, there isn't always a nurse there that can do this, or a nurse that's skilled in this area. So one of the interventions that we've developed is decision coaching around helping nurses, social workers, other healthcare team members learn around the skills around helping coach patients to think through the decision and think about what's important to them so that the patient can have a more active role in decision making. So what is coaching? So it's provided by a trained healthcare provider who is non-directive. Non-directive is underlined because it's super important that if I'm providing decision coaching to Nafisa, I don't say, oh, based on those guidelines I just showed you, you really should be having external radiation or in that situation I just shared. It's not my job. My job is really to be non-directive, help patients prepare to be involved in that decision by helping them understand their options, helping them think about what's important to them. It can be done face to face on the telephone or using other communication media, but not automatic. So a lot of systems have gone to the automated calling system, and it's not meant to be automated because in order to actually talk to people about what's important to them, you have to have a conversation with them, and you can't just automate, say, okay, just tell me automatically what you want. People who receive decision coaching are more likely to progress in the process of decision making and make choices that are more consistent with their own values and beliefs. So when we talk about decision coaching, we're not coaching about lifestyle change, behavioral change, trying to get people to increase exercise, take their pills. We're coaching them in the skills and thinking through what's the best decision for best option for them. So we have the Ottawa Personal Decision Guide, and we have the version for 1, and we also have a version for 2. This is the example of the version for 2. We developed it in a research study that was done at the Children's Hospital, where we had a child and a parent involved in making a decision around type of insulin delivery, whether to use a pump or continue to have multiple daily injections. And so in this, you at the top talk about the decision. You identify what are the options. So one was insulin pump, one was multiple daily injections. There was a third one, actually. We talked about what are the benefits of each of them, what are the reasons to avoid the option or disadvantages. And then for each one of these advantages, the person rates on a scale of 0 to 5, how important is that? So 0 is it's not important at all, 5 it's very important. What we're able to do is help understand the child's perspective by using a decision coach. And at CHIO, it actually was the social workers on the diabetes team that took on this role because they were the ones that were positioned to be able to have the conversation with the child and the parent. And the decision coach really invited the child to talk first before the parent to try and decrease that power imbalance. Because if we think it's bad between us and a physician in a healthcare setting, it's even worse with the child, the parent, and healthcare professional, because the child is really the least important, feels the least involved. And so we were actually able to involve the children down to age 6 on this project. And so our original work at CHIO was we just wanted children 12 and above, and ethics said we had to include all that could consent to participate. What we found on the project is that children with diabetes have had it for a long time, and they actually know their bodies and know their diabetes a lot. And so they were actually able to be very involved in how this decision was made. So in terms of the evidence around decision coaching, and the Cochrane review we did on this topic, which was led by Janet Jal, there are 28 randomized controlled trials with over 5,000 participants. 17 trials evaluated decision coaching with evidence-based information, and in these trials it improved knowledge and helped them prepare to make healthcare decisions. And there was no adverse effects or no harms in providing decision coaching. So the other intervention or decision tool that I want to talk about is patient decision aids. And so patient decision aids provide information on the facts around the condition, options, benefits, harms. Some decision aids also include probabilities or what's the chances of outcomes. Some help patients clarify their values by asking them which benefits and harms matter, or provide examples of patient experiences. And then some provide steps in how to think through the decision or a worksheet or list of questions. And if you think about the key elements of shared decision making, they're also implicated within patient decision aids. It focuses on a specific decision, has information, and also helps them clarify their values. So patient decision aids can be used prior to the consultation or within the consultation. They come in printed materials, videos, or also online or computer-based materials. So here's an example on a decision aid that was created over at Briere to actually look at the decision around flu shots for healthcare professionals, because people were pushing back and not wanting to get the flu shot. This is pre-COVID. Now we're getting shots on everything all the time, it seems. But here there were 3 options in the decision aid. So get the flu shot, wait until there's an outbreak, and then decline both and take antivirals, or then decline flu shot and antivirals. So there are three options presented in the decision aid. It presented the probabilities of fewer people get in the community get the flu if you get the flu shot. Here with the flu shot, only 5, with antivirals 4 versus 15. Fewer patients die from the flu if their care provider has the flu shot. And then what are the side effects? So you get a sore arm even when a placebo is given. So, and then nausea and vomiting with the antiviral medication. And then also the decision aid had a values clarification exercise where it asked people to think about what was the most important for the different features of the different options. So we just updated the Cochrane review of patient decision aids and published this in January of this year. The goal was to assess the effects of patient decision aids in adults considering treatment or screening decisions. Here's our team, but the reason why I want to show you who is on our team is we have people from many different countries, but we had 3 patients. Maureen Smith was on our executive and met with our team every 2 weeks. Janet Gunderson and Henning Sondergaard from Denmark, and Janet was from Saskatchewan. They were also part of the steering committee. So the results showed 209 randomized controlled trials now conducted in 19 countries. We flagged what are the new countries, and you can see several of these trials have been conducted in Canada. There's a huge number of topics that have been evaluated in these patient decision aids: medical topics, screening, surgery, obstetrics, vaccine. So just to give you an example, one of the hot topics in surgery is joint replacement, hip or knee replacement versus alternative options. In obstetrics, the big decision is what after cesarean, whether or not to have a vaginal birth. And so there's 5 on birth options. And then there are also on some on the vaccine one, the flu one I just showed you, the flu example. So in terms of our primary outcomes, we looked at decision quality, defined as informed values-based choice. It was evaluated in 21 trials. It improves by 75%. We also use the grade rating to look at how strong is the evidence. And so we got a 3 out of 4 on that one, and we got 4 out of 4 on the rest of the outcomes. And what that means is if there are 10 more trials done or 100 more trials done, that the evidence is going to stay consistent, like it's going to show improvement. So knowledge of options, 107 trials measured this. Knowledge improves by 12%. Realistic expectations improves by 94%. Feeling uninformed, it's a subscale of decisional conflict. People feel less uninformed or they feel more informed. They feel more clear about their values. And we also shift away from clinician-controlled decision-making to patients more involved in how the decisions get made. And so if I was to say to you right now, if you or a family member entered the healthcare system in the next week, how many of you would want to be involved in how a healthcare decision gets made for yourself or the other person? So all the hands are up. And which is right, actually. What we know is 95% of people want to be involved in decisions. And the people that don't is a small group of older people, like this case I showed you. Probably not that person, but definitely the daughter wanted to be involved. But what we know is as soon as you give someone a diagnosis of some kind of medical problem, the automatic response is, you're the expert, tell me what to do. But for many of these decisions, there's multiple options and it's not so straightforward. And so what we know with patient decision aids is we can help them get involved so that they can actually participate in decision making and feel more like they're in control. And I'm just doing a sub-paper on this secondary analysis looking at gender, the sex and gender question that CITAR always asks me to write about. And I never do, but I did the analysis. And what we found is of the 209 studies, none evaluated the effect on men and women in the same study. But we have a whole bunch of men's studies and we have a whole bunch of women-only studies. All the men's studies are in prostate, and then the women's studies are across a range of different decisions. Well, in prostate, there's different decisions in there. And interestingly, found that there was a higher significance of patient-controlled decisions in the men group, whereas in the women group, it was more shared or women controlled. But in both cases, we shift away from clinician controlled decision making. So I was surprised, but then looking at the literature, it's consistent with literature on men's perspectives on decision making versus women's. So the Cochrane Review, it was first published in 1999 in the British Medical Journal, and then in Cochrane around the same time by Annette O'Connor, and I've been updating it since she retired in 2010. It's the #1 cited review in the Cochrane Library of over 7,000 reviews, and it's now cited over 110 times by clinical practice guidelines. And so many guidelines now are saying we should be using, because the evidence is strong, these interventions. In 2003, though, because we'd already had a couple publications in Cochrane and BMJ, we started to get concerned around the quality because we knew they worked. And so to enhance quality and effectiveness, we want to set up an evidence-informed framework for improving content, development, implementation, and evaluation. And I co-lead the steering committee right now with Bob Vogt, who's at MD Anderson, and we have representatives from all over many different countries. But our concern was, and I get this all the time, I get approached by pharma drug industry to come and they want decision aids on their products. And I won't develop them because even if I was to develop them, I would get funded by them and there would be a perceived conflict of interest in those decision aids. So in the beginning, I worked with a dermatologist that wanted one in psoriasis and psoriasis treatment options. And they got the funding from the Canadian Psoriasis group that takes funding from industry, but groups from all of the different funding pots or from different industry. But even at that, it's still, we want to make sure that the decision aid doesn't have inherent bias within the way it's developed. So our evidence-informed framework has criteria set up in 3 different levels. The first is it a decision aid? And so these criteria must be met or else it doesn't qualify to be a decision aid. The second set of criteria does it employ strategies to reduce harmful bias? And these should be met, and we call them essential criteria. And the rest of the criteria we call enhancing around what could be done to improve the quality of the decision aid. But the criteria, when we first established them, there's over 80 criteria, and people are like, we can't do all 80. So this breakdown of the 3 different groupings has been really helpful. So this is what it looked like. We have the first IPDAS checklist published in 2005. It had 74 items at that time, but there were over 80 in the consensus. We went down to 47 items, and now we have the minimal standards, and we've just finished another update, and we're just finalizing next week. The steering committee is going to finalize what are the changes to the criteria. So if you want to find a patient decision aid, you just Google decision aid and you'll come to the website at the Ottawa Hospital Research Institute where we have the international inventory of decision aids. If you I just typed COVID in and it found 4 matches on COVID decision aids. If you click on one of those matches, it actually tells you where to go and get the decision aid. You can click here. Actually, we move that link up to just under the title. It tells you who created it, when it was created, but we also evaluate them all against the international standards. So here you can see it met 7 out of 7 criteria to be a decision aid and 8 out of 8 criteria to lower the risk of making a biased decision. And these are just what are the qualifying criteria, which I'll actually show on the next slide. Oh, I have 2 slides here. So in terms of qualifying criteria, it must identify the health condition. It must state what the decision is or the focus. It needs to identify the target audience. This is one of the new criteria that has been approved for being added in 2024. It used to be there, but only if probabilities were used, but most people identify the audience. It needs to describe options, positive features, negative features, and then help clarify values. In terms of the essential criteria, it needs to provide balanced or equal detail for negative positive features, has to cite the evidence that's used so that you can track how good is the evidence in the decision aid, should have a production date, update policy, It should have information about the uncertainty around probabilities, if probabilities are used, and then what are the funding sources for development, not necessarily for publishing like it, because there might be costs, but for developing it. Then we have a number of other criteria for screening, like breast cancer screening or prostate screening. And then this is examples of other domains. And so IPDAS actually has a nice section on health literacy and trying to improve the way in which the information is communicated in plain language. It has specific criteria. It has really good criteria for if you're going to present probabilities, what are best practices and evidence-based practices for presenting probabilities. So Washington State Healthcare Authority in 2016 adopted IPDAS, we call it IPDAS, criteria for this first certification program in the world, and they use our criteria. The criteria are also used by the Norwegian government, in the Netherlands, in the UK, in the NICE guidance around decision aids. And so many different authorities have adopted the criteria, but this is the only certification program. So we've also found the IPDAS really helpful for looking at patient ed materials and to look at, are they any good and are they helpful for decision making? So this was an environmental scan that Alda Kiss, one of my students, did on medical assistance and dying resources in Canada. And so she looked at all of the government materials and evaluated them with IPDAS. So none were decision aids. And we also used PMAT for health literacy to look at were they understandable or actionable? And what we found is understandability was moderate and actionability was poor. And so anyway, the IPDAS are helpful for going beyond decision aids, for looking at different types of resources. So I'd like to just spend the last few minutes talking about implementation. So in 2017, we published the Cochrane Review. And at that time, there were over 100 trials, and we just doubled it in our recent public update. So I went back and I emailed all of the authors, and we had 92.5% response rate saying, after the trial, what did you do with your decision aid? And only 26.9% of the patient decision aids were implemented post-RCT. And what we wanted to know from the authors is why? Like, you did the trial, it worked, like why isn't it being used? And what they said is the barriers were the lack of a post-trial plan, like people just, the goal was to evaluate it, and they did, and that was what they were supposed to do. The decision aid content was outdated, and they had no funding to update it. Clinicians disagreed with its use, and this happens actually all the time in the implementation studies, because they say, well, I'll tell the patients what the chances are. And I was doing a project in prostate cancer treatment in Saskatchewan and Ottawa. And when I talked to the surgeons, they were like, oh, none of my patients have incontinence after surgery. And I'm like, really? And so the evidence shows that up to 75% have incontinence after surgery. And then the Ottawa Hospital implemented, it's called EPIC, for measuring prostate side effects after surgery. There's also EPIC, the electronic health record. There's two EPICs. And then they started giving the surgeons their report cards that would show what's patients' quality of life after prostate surgery. And suddenly they realized their patients had incontinence. And so it was a really good example where clinicians actually don't know what's the chances of outcomes of their own patient population. They only know those that complain to them. They don't know the real case of what happens. So anyway, so that's why clinicians often don't agree with the probabilities and say, no, that doesn't happen to my patients. We also, another barrier was infrastructure support and funding. So how are we going to put them in the hospital or integrate them into care? The facilitators, if it was web-based delivery, then it's easier to access. If it was endorsed by government or organizations, then it's more authority on it than just it's Stacey's decision aid. And then if it's designed to fit within care process. And so when we look at implementation now, this is the IPDAS implementation group recommendations. They recommend decision aid should be co-produced for content and processes or locally adapted, but co-produced with patients on the team. We've just done a network meta-analysis that actually looked at there's even better knowledge outcome, the outcome of knowledge is even higher when patients are on the development team. And so we should be developing these with patients and healthcare professionals. We should train the whole team in how to use decision aids in the clinical care. We should prepare and prompt patients to engage. So prompting could be the ask intervention by saying you can ask, or giving them the decision aid ahead of a consult if there's time to do that. We need senior level buy-in or leadership support for doing this. And we also need to measure to improve, like what are the outcomes we're measuring, and how are we feeding them back into the system? So two huge implementation projects that have been done in Denmark and Germany. You can see actually where they have looked at, in the Denmark one, they looked at training leaders, the process for in which shared decision-making is going to be used. They call their patient decision aids decision helpers. And then they provided training of the teachers and the clinicians across all different areas. In the Hamburg, Germany study, they actually provide training, coaching for physicians, patient activation, like the ask intervention, patient decision aids, revision of the quality of the management documents, and then look at multidisciplinary team meetings. And so the Germany one actually proved to the health insurance in Germany that they did such a good job that they actually are funding this as part of routine practice across the hospital. And they developed, I think, around 75 decision aids for that hospital that could be then integrated within the process of care. And then this site in Denmark, they've actually changed the whole culture to be patient focused. And I've never, like I'm on their advisory board, so I get to go often to see and go into the clinical areas and talk to the physicians, talk to the nurses, and they really honestly value the patient's voice and how decisions are made. And they've been at it for 10 years. So, but they changed the whole culture in which this is done. And they've had amazing leadership support to do this. So just a couple of slides and wrapping up. Decision aids are required actually in the US for funding at Centers for Medicare and Medicaid. And so this is an example of two. For lung cancer screening, if a decision aid's used, there's reimbursement for that discussion. And use of anticoagulation prior to approval of reimbursement for the Watchman LAA closure device is a cardiac procedure that's quite intense. And again, and they actually have a list of others where there is funding for use of patient decision aids. But they can only bring this in for new things. So we said, how come you don't fund prostate cancer screening decisions, which has been around, and they recommend decision aids since the 90s. And they said, oh no, because that's been around too long. It's only when a new thing comes in, like lung cancer screening is quite new, that then they can actually tie it to funding if a decision aid's used. But this has also meant that there's a whole pile of places in the US developing decision aids that don't even know what a decision aid is, or because there's an incentive to do something to make money. In Australia, I've also done work in Melbourne with the Victoria Health, and they actually have, and also with the Australian Commission on Safety and Quality in Healthcare, and they actually integrated it into the accreditation standards. And so now in standard 2, it says partnering patients in their own care, and there needs to be shared evidence of shared decision-making, use of decision aids. And so on my last sabbatical, I was able to go there and work with the hospitals to figure out how are they preparing for accreditation to indicate they're doing this. And then we also set up pilot projects with 6 of the hospitals, 3 rural, 3 urban, to try and look at how do they improve the way that they provide support patients in decision making.